eye, but a lot of it comes from systemic conditions that I, as the optometrist, would see, and we would work together to better manage these patients. All right, so looking at, let's turn this way. All right, so this is the blueprint, and then for today's lecture, specifically, we'll go over quite a few different retinal conditions, some vessel occlusion conditions, diabetic retinopathy, retinitis pigmentosa, retinal detachment, age-related macular degeneration, hypertensive retinopathy, and then finally wrapping up with bullseye retinopathy. So quick anatomy of the retina. When you are looking straight into the patient's eyes, so during like direct ophthalmoscope, you are looking at the posterior pole of the retina, and that is where you're going to see the macula. That is the most visually sensitive part of the retina. And within that macular region, you're going to see the fovea. Now the fovea, at the center of it is the foveola. And for younger patients, you might see this light reflex that bounces off of it. More difficult with our older patients. This area tends to be slightly darker and it lacks vascularity. Outside of that posterior pole, we'll go into the mid-periphery and then the peripheral parts of the retina. So with your DO looking into the eye, those structures are going to be impossible to see. And that's where if you've gone in for an eye exam and had your eyes dilated, the optometrist will put a BIO, a binocular indirect ophthalmoscope, so that we can better assess the farther parts of the retina. Moving nasally, it is going to be where the optic nerve is, and that's that yellow spot in the back of the eye. And that's what connects the eyes to the brain. The part that we see is the insertion portion of that optic nerve, and we'll assess the appearance, the color, the sizing of it during our assessment. The vasculature of the retina, you'll have your arteries and your veins. The arteries tend to be smaller than the veins. The color is a little bit different as well. The arteries are an orange-red color, and then the veins tend to be a little bit darker. Your normal assessment of the size, the diameter of those vessels is a 2 to 3 ratio. So the way you look at it is that the diameter of the artery is about 67% of the diameter of the veins. And anytime you have a deviation of that ratio, it'll tell you that there's something going on vascular-wise. The arteries and veins are besties. They travel together, and they tend to cross over one another. So when you're assessing the back of the eyes, you won't see a vein crossing over a vein, and you won't see an artery crossing over an artery. You have 2 blood supplies to the retina. You have your central retinal artery, and that'll supply the inner part of the retina. So if you just picture yourself standing in the vitreous, looking at that inner layer, the layer that is closer to you is what we consider the inner retina, and that they said that's supplied by the central retinal artery. And then anything further is going to be the outer retina, which is supplied by the choroid. For the most part, the retina is clear, transparent in color, and what gives off that coloration is going to be your retinal pigment epithelium. So if you have less pigment, we tend to call it a blonde fundus, and then if there's a little bit more pigment, it is a brunette. I don't ever use that term. It's just a blonde fundus or it's not. Here's a picture going over the different structures. The thing to point out is the branching points. So if you look at that yellow spot, that optic nerve, and the vessel that comes out through it and then feeds and fans the retina, where it starts to branch off is that branching point. So when you get to the point where you're doing a direct ophthalmoscope and you're looking into the patient's eye and you're like, I don't know where I'm looking. I see this fundus and I see these red lines. If you follow and try to find that branching point, that V to that branch will point you in the direction where that optic nerve is. So just find that and then follow it and it'll take you to the optic nerve. Now the inner retina is where the nerve fiber layer and the ganglion cell nuclei is located. And so basically this takes the electrical and chemical signals that the retina receives and sends it to the brain. This is also where all the retinal vasculature is located. So if you have an ischemic condition, the clinical signs will appear in that layer. Here's a schematic drawing of the retinal layers. The top is the innermost layer, so it starts with the inner limiting membrane. And if you follow the layers down, it ends with the RPE, the retinal pigment epithelium. So in the clinic, we do have equipment that will allow us to actually look at the different layers of the retina. The bottom right corner picture is from an OCT, so an optical coherence tomography. And so this allows us to see more subtle changes in the retina. When we're looking into the eye, sometimes these things are just a little bit hard to see, and when you can break it down to the different layers, you can pinpoint where the abnormality is occurring. So first condition that we're going to go over is the artery occlusion, and that can be either with the central retinal artery or the branch retinal artery. The central retinal artery tends to cause more severe visual consequences than your branch retinal artery occlusions. The branch retinal artery occlusions tend to respect the midline or the horizontal line. Now this is due to some sort of thrombosis or embolism. And this all occurs unilaterally, so one eye. Depending on where it is, the patient may notice, and the consequences, their visual changes are very obvious, but sometimes it's not noticeable until they close one eye. You can have macular sparing. 20% of our population will have what we call a cilioretinal artery that feeds the macula, and it's separate from that central retinal artery system. Your associated risk for the artery occlusions comes from a thrombosis, like I said, an emboli, oral contraceptives where it increases coagulation, and then giant cell arteritis. This is a close-up of the retinal vasculature. So just like we were saying with the first retinal anatomy slide, that the fovea is avascular, so that's where that empty space is, and that is where the choroid is supplying the vasculature. So going to specifics, the CRAO, so your central retinal artery occlusion. Again, unilateral, painless, sudden vision loss, acute vision loss. This is extremely detrimental to the vision because patients can be left with light perception where they're not able to see letters at all. It's just the appearance of light or no light, or it can be even worse. Now, due to its severity, patients will end up with an afferent pupillary defect. This happens quick, so time is of the essence when we're trying to treat the patient. It's also more noticeable or noted that the symptoms occur early in the morning when they wake up. Now, during the exam, classic signs of a CRAO, right? You look into the fundus, it is a pale, it's a white color with a cherry red spot. So looking over into the macula, you'll just see this red area. Sometimes you'll have maybe a little bit of coloration over that retina instead of just that solo cherry red spot, and that's, again, due to the cilioretinal artery supplying blood to that macula. So here's a picture of it. The fundus, the retina, is a little bit pale, and then right over the macula is just that cherry red spot. Fluorescein angiogram, that's done with ophthalmology, and a dye is injected, and it allows us to better assess the vasculature going on in the retina. And this is showing a patient who has a CRAO when we're looking straight into the eye, and then how poor the perfusion that's going on with the fluorescein angiogram. Here's that macular sparing that we were talking about. So pale fundus, and then now instead of just a cherry red spot, you have this area that is a little bit pigmented. It's a little bit more red in color. Prognosis is poor. Over time, that cloudiness of the retina and the cherry red spot may disappear. And what we need to look out for is new blood vessels growing, so neovascularization of either the iris in the front of the eyes and the angle, and then even in the back of the eyes where the optic nerve disc is located and different parts of the retina. And we travel further out, away from that central retinal artery where it starts to branch. You can have an occlusion there, and that's when we change the nomenclature to a branch retinal artery occlusion. Similar symptoms, just less severe. Right? And you'll also get the whitening or that pale look to the retina, and it's just a certain sector of it, so a certain part of it that is being affected by the occlusion. In this picture here, you'll just see a slight pallor appearance to the retina, so just right here in comparison. I see it over here. So just a slight pallor look to the retina. And here's a little bit more obvious. So prognosis is still poor unless if the obstruction is relieved and properly done within a few hours. That visual field defect will be permanent though. And neovascularization is typically rare in these cases. All right, so your workup, some lab work, that this is where I would send my patients to you guys as their PCM. Would do that, and then I would take care of the dilated fundus exam. All right, so ophthalmology referral for the treatment, and the treatment theory is basically to decrease that ocular pressure and break that occlusion. So if you can have an occlusion in the arteries, you can also have an occlusion in the veins. And so same thing, instead of a central retinal artery occlusion, you'll have a central retinal vein occlusion and then the branch retinal vein occlusion. This also respects the midline, the horizontal midline. And the pathophysiology for this is a thickening of the arteriole, compresses the vein, causing stagnation of outward blood flow. Long list of associated risk factors, and these conditions are the same ones that you would worry that would increase the patient's risk for heart and blood vessel problems. Glaucoma is also an ocular condition that increases the risk for retinal vein occlusions. So just like your CRAO, your CRVO causes sudden painless unilateral vision loss. You have two different types, your ischemic and your non-ischemic. The non-ischemic tends to be milder, and fortunately, it tends to be the more common between the two. So for your CRVO, instead of like the CRAO where you have a pale fundus, this is a fundus where there's a lot of hemorrhaging going on, so we tend to call it a blood and thunder fundus. The types of hemorrhage is a dot and blot or a flame-shaped heme. You can see little white fluffy areas, which we call cotton wool spots, and then some exudates. You also can see some optic nerve swelling. So your CRVO, the white fluffy areas down in the inferior, the bottom portion of that picture, is what we call a cotton wool spot. So you have some right here, some right here, and then some hemorrhaging up here. Same thing, you'll have your cotton wool spots down here, some exudates, and then some bleeding up here. Here's that red blood and thunder eye. Another example of it. So for your ischemic CRVO, prognosis is poor. Right, about half of those who end up with the CRVO will end up developing neovascularization of the iris. And then for your non-ischemic, the milder form has the potential of becoming ischemic, as well as developing macular edema. So shared signs and symptoms between the CRVO and the branch retinal vein occlusion. So with your branch, it's going to only occur in a certain part of the retina. And so again, you're not going to see blood and thunder throughout the entire fundus. It's just going to be in that section. So for this case, it's going to be that bottom portion of the retina. All right, and then same thing right here. The bottom right is that fluorescein angiogram that highlights that vasculature. And then when you piece together the different pictures of the fundus to get an overall look, you can see how it just happens in just one section of the retina. So the prognosis is good for a BRVO, right? 50% tends to develop collaterals to help improve visual acuity. You can develop chronic macular edema or neovascularization at some point, and that will complicate the visual recovery for these patients. Your workup is, again, very similar to a CRVO, or your CRVOs and your BRVOs. The workup is going to be very similar. You're going to order blood tests, lab work, and from an optometry standpoint, we're doing the complete eye exam, checking the IOP, so the intraocular pressure, and then seeing if there's an apparent pupillary defect. Ischemic form, the severe form, we're going to see the APD, and then the non-ischemic, not so much. So for these patients, the treatment is treating what that underlying issue is, and then referring to ophthalmology, especially if there's neovascularization going on, because injections and possibly laser surgery, so PRP, it may be required. All right, we love tables. I love tables. It organizes all the slides and all the information into a little easier process to study. So I go over that. All right, diabetes. So this is the leading cause of blindness for those in our country between the ages of 20 to 64. So whenever you diagnose a patient with diabetes, a referral to optometry for a full fundus exam is recommended, and preferably within the first 6 months. All right, so when they come in, they'll get the vision aspect of it, but they also will be dilated. And that's where we get a good baseline of how things look in the back of the eyes. I always say diabetic retinopathy is a disease of time. So typically, if it's newly diagnosed, we're not going to see retinopathy, especially with your type 1s. Now, type 2s, they might have had these symptoms where they've had diabetes just undiagnosed. So some, at their initial visit with me, we may see some hemorrhaging going on in the back of the eye. But for the most part, most of my patients that I've seen for their first exam is pretty normal. And about up to 90% of patients who have type 1 will develop proliferative diabetic retinopathy after 30 years. So like I said, a disease of time. The longer they've had it, the more likely they're going to develop some sort of diabetic retinopathy. All right, so the length of time, how well it's controlled, sometimes hormones can cause the progression and the speed of progression of retinopathy. We have 2 different types. We have the non-proliferative and the proliferative. So with both, so the milder form early on will be your non-proliferative. You'll have hemorrhaging going on in the back of the eyes, some microaneurysms, exudates, those white fluffy spots, the cotton wool spots, and intraretinal microvascular anomalies, so IRMA. In the late stages of diabetic retinopathy, we will call it proliferative, and that's when new blood vessels tend to grow. So again, neovascularization is occurring. Now, outside of diabetic retinopathy, you can have diabetic macular edema. So you don't necessarily have to have the late stage in order to have macular edema, which is the swelling of the macular area. All right, so the vascular endothelium tight junctions, they form the blood-retina barrier. And with diabetes, that weakens. And so you end up getting leakage of the intravascular fluid into the retinal tissue. And that can accumulate. If it's underneath the macula in the fovea area, you're going to end up with decreased visual acuity. The severity of your non-proliferative diabetic retinopathy depends on what you see. So do you see the dot and blot hemes? Do you see the microaneurysms, exudates, cotton wool spots? And you also look at how many of that is, if you break up your retina into, say, 4 quadrants, and how many quadrants are involved, right? So the more severe is going to have more of the retina involved, and you're also going to see more of these clinical findings. So your mild NPDR, so non-proliferative diabetic retinopathy, you'll have a couple of dot and blot hemes, so little red spots, and then the little yellow specks that you see there are the exudates. This is obviously more than just mild diabetic retinopathy, or mild non-proliferative diabetic retinopathy. And then I think there's a circle. Yep. So the circle highlights where you find IRMA. Even as an optometrist looking in the eye in a dilated fundus, pinpointing IRMA versus neovascularization tends to be a little bit difficult. So I would never expect y'all to be able to find that, nor would it be fair. All right. So proliferative diabetic retinopathy, PDR. Right? This results from ischemia, and so when that happens, you have the stimulation for new blood vessels growing, and when we have new blood vessels growing, we call it neovascularization. And that typically happens when it follows the path of that blood vessel fanning over and feeding the retina. So that's what we call the vascular arcades. But you can also have neo over the disc, other places in the retina, and then even to the front parts of the eye at the iris. These vessels are fragile and they tend to leak, and so you get recurrent hemorrhaging going on. Patients with PDR, even though it's in the late stages of diabetic retinopathy, can still have 20/20 vision. Again, if it's not affecting their macula, vision tends to be spared. And because of that, some patients are unaware of the visual changes. And over time, it may change, but usually slowly. And patients can complain about floaters, especially if there's hemorrhaging into the vitreous. Blind spots or scotomas can develop as well. So your neovascularization, when you're looking at it on the retina, tends to be this fine, lacy appearance. And like I said, it can happen anywhere. So you want to look, when we're assessing it, we're looking at the optic nerve, we're looking at other parts of the retina, as well as the front part of the eyes at the iris. Now, if that neovascularization or that blood vessel starts to leak and it ends up hemorrhaging, especially if it's on the retina, then it tends to give a very classic appearance, and we call it a boat-shaped heme or a pre-retinal hemorrhage. You can see those white fluffy spots, the cotton wool spots, dot and blot hemorrhages, and if there is that heme, you may have a loss of red reflex. All right, so PDR. So right over the optic nerve, you'll see this fine lacy kind of webbing of the blood vessels. That is neovascularization of the disc. So if you're ever looking at an optometry note, you'll see it as NVD. Right over here. And again, fluorescein angiogram helps with seeing where that leakage and the vasculature going on in the retina. Now, if it gets really bad where you start to develop some fibrovascular scarring, you can end up with a type of retinal detachment. And so this right here, that fibrovascular tissue is this white stuff. Over here as well. All right, so again, NVD is neovascularization of the disc. And we're not very creative, so NV is neovascularization elsewhere. And then the picture on the right is a picture of a pre-retinal hemorrhage, so that boat shape Heent. So it just follows, it's a flat top with a curved bottom. All right, so the workup you guys will do, and that's the typical workup for diabetes, right? And then from the optometry standpoint, we will do the fundoscopic exam. It's within that first 6 months after diagnosis. If everything looks good, we'll see them annually, and then depending on what we see, if it's really bad, we'll change the frequency at which we'll see them. All right, so for your non-proliferative, so no neovascularization going on, it's basically tight control of their glucose. All right, that's where that coordinated care between the PCM and the optometrist happens. Now, if there is neovascularization going on, then that is a referral to ophthalmology because typically they'll get injections, an anti-VEGF, or if it's really bad, then they'll go ahead and do PRP, so pan-retinal photocoagulation. Here's an example of what PRP looks like. We go in and zap different parts of the retina. It reduces the release of VEGF, so no new blood vessels growing in hopes of preserving vision. So you can have diabetic macular edema even with non-proliferative diabetic retinopathy. So depending on where in the macular region, some patients may not even notice any symptoms. Now, vision may be decreased in one eye or in both eyes. There's some aneurysms going on. There's dot and blot hemes and exudates as well in that area. And then here's a picture of what diabetic macular edema. So it looks very similar to diabetic retinopathy, right? But then it's localized to a specific part of the retina, so over that macular region. All right, here's an OCT of the retina. And on the left side, that little, it's almost like a triangle, pyramid looking white space right here. There's fluid that's collected there. And then right here. And then the right picture is after a patient has gone through treatment and the retina, or that macula, kind of resembles a more normal looking macula. So your workup for DME, so diabetic macular edema, is the same as your PDR. And in this picture, it'll highlight what a microaneurysm looks like. So it's the little white triangles versus the bigger triangle that's highlighting the exudate. All right, I'm zipping through this. So retinitis pigmentosa. This is a visually devastating condition, and unfortunately, it's not a condition where you just told a patient to eat better and exercise. It doesn't happen very often. I mean, I've been practicing 15. School was 4 years. You lump that on top of it, and I've only encountered one patient, or not even a patient, but one person who has had retinitis pigmentosa, or RP. This condition is typically diagnosed between the ages of 10 to maybe 30. But a lot of times with your younger ones, unless there's a family history of it, a lot of times it's when kids start complaining about, like, I can't see the board very well, the fundus looks pretty normal. So actually diagnosing a non-inherited pattern of RP is pretty difficult for that age group. I think a student of ours over at the ophthalmic technician program, by chance during the lab portion where we're learning how to do different ancillary testing, that they noticed it. So again, really, really tough, but it's a situation where a patient is born with sight and then over time they lose it, right? And that it starts to affect their activities of daily living and would require more than just, say, glasses and contact lenses. So when we say retinitis pigmentosa, we're talking about this umbrella term, right? It's a large group of retinal degenerations. Most are inherited, not all. And it starts off, well, it affects the photoreceptors, but it starts off with affecting your rods. And then over time, it'll affect your cones. And it also causes some pigmentary changes in the retina, especially the retinal pigment epithelium layer. So like I said, it starts off with the rods. So the symptoms that the patient would experience is going to be associated at first from the rods. So you're talking about night blindness, you're talking about difficult seeing at night, especially driving. That tends to be the most common complaint. Your peripheral vision decreases. And then eventually it starts moving towards your cones. So you start thinking about what your cones are responsible for. And so primarily it's your vision, right? And so there's a decrease in vision and then a loss of color vision. So the one person I knew, it was an instructor in optometry school, and he said that it started off with just everything started coming down and ended up with tunnel vision, and then now it's been quite some time since optometry school, but when I met him, it was just a pinpoint at that point. Walking around with a guide cane, and you know, when you talk to him, you kind of gotta make sure you're right in front. Handing things to him, you gotta make sure it's in the line of sight. So lots of modifications. All right, so when we are looking in the eye, right, early stages fundus might look very normal. Over time, you can end up with bilateral, meaning both eyes, some pigmentary changes in the mid-periphery, and those changes we call bone spicule. You can see some narrowing of the vessel, and the optic nerve tends to be a little bit paler in color. You can also notice some yellowish or a white halo around the optic disc. And the type of cataracts, I know you guys went over that yesterday, the posterior subcapsular cataract is associated with RP. So this is a picture of what bone spicules would look like in the back of the eye. And it could be all throughout the retina, or it could be in just this section. All right, so workup-wise, they'll come in, we'll do a visual exam, we'll take a look in the back of the eyes. Case history is really important. There's certain tests that we can do, like a visual fields test, and that would be done with us in optometry. You can do an ERG, and that tends to be more ophthalmology's lane. And as far as treatment goes, if you're treating, it really depends on the genetic condition. Sometimes vitamins can help with it. But at some point, low vision therapy or low vision aid is going to be needed, and that typically is not done with your general optometrist, right? There are folks that have gone on to do some specialized training, and we're looking at devices outside of glasses, right? Magnification, there's certain filters, there's a bunch of different aids that we can help. All right, retinal detachment. I think we alluded to this a little bit yesterday as well. So when we're talking about retinal detachment, we want to think that the retina is now separating from the retinal pigment epithelium, right? And it's usually because there's some sort of fluid that forms within that space. Now there's 3 different types of retinal detachment. Regimatogenous is the most common one, and that's when there's a break or some sort of tear that happens in the retina that causes fluid to get underneath and starts to separate the retina from the RPE. We tend to see this in our high myopes, so our high nearsighted patients. So typically when I do a routine eye exam, even if the patient is asymptomatic, if they have a high prescription, let's say probably higher than a -5 or -6, I go through the blanket statement of what to look out for, and if you do notice it, to give us a call immediately. All right, the next form is your exudative retinal detachment, and this happens when without a break. All right, and this is usually from something under, like deeper in the retina, so maybe like a tumor. And then tractional retinal detachment, and this is when that fibrovascular tissue or some scarring pulls on the retina and then it pulls it away from the RPE. We saw a picture of it a few slides back with the diabetic proliferative diabetic retinopathy. And then you can also see this with patients who have retinopathy of prematurity, so ROP. So classic signs, this is where education is really important. I always tell patients, if you have a new onset of flashing lights, new onset of floaters, and it's just not this one floater, but it tends to be a lot of floaters, or if you feel like there's a curtain or a veil covering parts of your vision, it could be all of your vision, that you want to come in and have us take a look at it. So those are the 3 signs that we typically mention to patients, right? New onset of flashes, new onset of floaters, and a curtain or a veil covering parts of your vision or all of your vision. Some patients will say that they experience metamorphopsia, so some distortion or waviness to their vision. And depending on how severe, you can end up with a relative afferent pupillary defect. So here's a schematic drawing of a retinal detachment. So you'll have a retinal tear. This is with your regimatogenous one. You'll have a tear, fluid gets underneath, that retina bubbles up kind of in this picture, so it's separating, and then that's that detachment. All right, this one might be a little bit difficult to see on this. You can also appreciate the elevation of the retina. So you have some rippling right here. It bubbles up, and if you follow this blood vessel, it looks like it kind of dives deep down into the rest of the retina. So same thing on this side. This part of the retina is elevated. You have some rippling right here. And if you follow this blood vessel and this blood vessel, it looks like it takes a deep nosedive down into the rest of the retina. A little bit easier to see with this one, with the exudative retinal detachment. So in that upper left corner of that picture, you'll see that the retina just looks like it's more elevated than the rest of the retina. And again, that's something that's coming from deep down in that retina that's causing it. There's no break, there's no tear with this. And here's a repeat picture from earlier with our proliferative diabetic retinopathy. So you can have a tractional RD with it. And another example of it. Okay. So as an optometrist, we're not treating a retinal detachment. So these patients will be referred to ophthalmology. It's extremely difficult to diagnose with direct ophthalmoscope, right? When you're in there, I mean, even from like a practicing optometrist standpoint, looking in with a DO, you're piecemealing all the different sections that you're seeing. So again, it's really, really difficult to appreciate a retinal detachment there. If it's bad, it can affect the red reflex, so maybe that can assist with your diagnosis. But the best thing is to dilate the patient, look in there, and assess all parts of that retina. Now, if it's a regimatogenous retinal detachment, there's two different procedures that ophthalmology can perform. So the first one is your pneumatic retinopexy, and that's where they inject a gas bubble into the eye after they fix the retina, and that bubble will rise and help push that retina and keep it up against the rest of the eye. Depending on the material or the type of gas that they use, it'll dissipate between a couple months to maybe a few months. There's no need to go in to the eye to remove that gas bubble. The other procedure is a scleral buckle, and that's where they put this silicone belt around the outer globe, and the whole purpose is to fix the retina and then now bring the rest of the eye closer to that detached part to keep it intact. Now, if it's a tractional retinal detachment, they may need to do a vitrectomy, remove that vitreous. All right. A couple more before we go on break. So ARMD, age-related macular degeneration. Right. A lot in advertisements, and a lot of people think they have it because it's a hot term, but it's the most common cause of legal blindness over the age of 60 in the Western world, so in our country. There's two types, just like diabetic retinopathy. There is a dry form, where we call it a non-exudative macular degeneration, and that tends to be the more common type. And then you have the wet form of macular degeneration, the exudative form of it. Regardless of the type of macular degeneration, you're going to see drusen's, and that's over that macular area. It's a yellowish deposit that happens there. All right, so the actual cause of AMD is not known, but there are risk factors for it that we've seen. It tends to be in a disease of age, so our older patients, and then they say female gender. I think this is closely associated with the older age. Female tend to outlive male, and so we'll see that higher in them. Lighter pigmentation, so pigment tends to be a protective mechanism for this. Higher rate in those who smoke, and there's some suspected genetic predisposition as well. So signs and symptoms of dry AMD, all right? It's this gradual loss of central vision. So remember, macula, center of the retina, responsible for central vision. And during the exam, when we look into the eyes, in that macular region, you'll see these little yellow spots that we call drusen, and you can have some pigmentary changes, so the clumping of pigment can occur in that area as well. Now, if we have wet AMD, patients will typically report some distortion to their vision. So straight lines don't appear so straight, and that's what we call metamorphopsia. The change in vision tends to be rapid, so no longer gradual like dry AMD. And again, same thing, we're going to see drusen's, we can see some pigment changes, but the main difference is now you're going to see neovascularization occurring. So wet, bleeding, neovascularization. Here's a picture of dry AMD. So you have some drusen's going on. And then you can end up with geographic atrophy. So basically that there's atrophy of the outer retinal layer in the macular area, and then this can cause permanent loss of vision. All right. So the risk factors for going from like dry to wet is basically the same risk factors of developing AMD. And then with our wet AMD, you'll see some neovascularization going on, some bleeding going on in the macula. So that's depicted in the left picture. And then if you want to go into detail with the fluorescein, you can see that pattern of the perfusion going on. Workup in the eye clinic. All right, we're going to do an Answer grid test on them, and that's some of the pictures in the back where there was like a few slides back, that grid test. And this is how we document any central field loss. The patient actually tells us what they see, and they draw it on that piece of paper themselves. You do this during their exam, and then we typically give that to them to take home so that they can monitor it in between visits with us. Intravenous fluorescein angiography, so that black and white picture that highlights the vasculature. We'll look at the macula behind the slit lamp, and then also evaluate family members for inherited patterns if we're suspecting it. So this is that Answer grid test, right? So a graph test, the center part is the fixation target. And so I typically ask my patients 4 questions. We do this one eye at a time. And because they're older, right, we'll have them put on their reading glasses. And so I'll tell the patient, Mr. So-and-so, can you see that center dot? And then they'll say yes. All right, so while looking at that center dot, can you see all 4 corners of that grid? Because if you don't tell them to look at that fixation target, they're going to actually scan and look for those 4 corners. Same thing, looking at that center dot, do all the lines look straight? And then again, looking at that center dot, any parts of the grid missing? And the patient will we'll hand them the pencil, they'll mark it, and then we'll scan that into their medical records. And this could be what a patient would report. This is highlighting metamorphopsia, so straight lines do not appear straight anymore. All right, last one before we go break. All right, so the treatment for AMD. So dry form, we can recommend some high dose vitamins. These are approved through an ARED study. All right, and these are really high dose. And this is typically more reserved for our moderate to severe form of AMD. It's shown to reduce the risk of progression by 25%. You want to be extra careful when you're recommending these vitamins to your patients who smoke. So high doses of beta-carotene in smokers have been associated for a risk of lung cancer. So luckily, there are ARED formulated vitamins that does not have beta-carotene. So again, education, super duper important. Wet macular degeneration, because there's neovascularization, so new blood vessels growing, bleeding going on. Ophthalmology would take a look at these patients, possibly doing intravitreal injections of an anti-VEGF agent, maybe some laser photocoagulation, and to know exactly what to do, they're going to do an angiography. All right. This is visually disabling. It's our central vision, right? And so as the condition progresses, just like RP, low vision aids may be needed to help get these patients through their normal daily activities. All right. Any questions so far? It's a lot I just threw at you guys. Yeah. All right. Let's take a break. 10-minute break.
I just got a bit. Imagine they never catch you. I see my name's not on the roster. Jesse. So it's just.
For the 24 hours.
Hey, bro. It's good. 3 minutes? 35. Oh, do you know what? Hey, let's do 1 minute.
1 minute?
Let's go.
We need to do one. He's thinking it's all this time. My son had chicken French fries. Can we get a coloring, please? It's good.
She'll stop at like that.
The whole game.
Dude, that would be things 1 minute, it's like I can't think.
So like in that small little square box, we use the same set, same quantity and sauce. Everything was fair, minus him playing music. He stood at the spot. I know the spot, so like I jumped shit. I just jumped the spot. You let me go 5 times, you're not getting it. He stood there for 5 minutes. Did not. Let me go 5 times. He's like, alright, I'm ready. I thought it was like every time I walk in,
I'm putting on you. All right.
you can also see like you killed him.
Yeah, really.
Whenever I'm already shooting, I'll get some I'm dead. I'm like, that makes no sense. I watch the video, I can even get a shot off.
But also, when you walked in,
I get my
I'm not happy.
Can you just say like you just keep that, but like arguably it's the most expensive. Still Lucas.
He's infiltrated the race. Oh! He's like that. He's so much
And he was cool. He was like, because I saw my own patients too, right? So he was like, you're only here for a couple hours. Oh yeah. Give you like the whole 8-hour whatever. And the days I would usually show up for training days. So like after they're done, yeah. So it's short day, Wednesdays too. So I never really so those were like the only days I was free. Man, I love you. There's only one moment I had with it. Yeah, I think that's when like we like clicked. It was like at the beginning. There was this one kid. He's like, what did you think about it? And I was like, oh, dude, I know. He's like,
Never been that much for a walk.
someone that killed Mom. He looked exactly like the guy who took your
I rarely ask you.
I want to ask him
Did you see the one about like guy about a new word on
Oh, yeah, it's alright. He's like, I want some 16 bucks.
You gonna stand and desk now?
I wonder if they would.
Bird. I'll be that guy. I said they're supposed to 25 bucks.
maybe they have to
Wait, you're going on 4.5.
God, if I was resting fat, I think I'd have hypothyroidism. And hair loss. I don't have any issue with that. I need to lose some hair. I need to.
I need that glass, right?
Excessive eyebrows, eyebrow maintenance. It's
Come on, bring up now.
That's when you're in bad shape. You gotta start cleaning out the eardrums. No. He didn't care.
Oh. Well, I mean, like, what's it?
Yeah. His ears in his 50s, yeah. He got pretty nice.
That's how cool they are.
Yeah.
Right now. Oh, yeah.
Unless you get those like summer tomato
Like, what? How do you drink it? It's like you're just telling my daughter maybe every day. Yeah. And they're all dead.
There's something about his past that so not diffused, but it's the whole thing.
Yeah, he told me like his family is like well known as like high end. So every time he goes back, like everyone like knows how he is because of his family. That's kind of cool.
That's pretty cool.
Yeah, but like,
Alrighty. Just a couple more conditions. Right, so we'll start off with hypertensive retinopathy. So hypertensive retinopathy, there is chronic hypertensive change going on. Hallmark sign is diffuse arteriolar narrowing, and then the thickening of the vascular wall. So that AV ratio that we were talking about with a normal fundus would be a 2 to 3. We're going to see a deviation, smaller ratio now, maybe a 1 to 3 to a 1 to 4. You can have some copper wiring of the vessel. So when you're looking at it with that light that's bouncing off of that vessel, there's this yellowish color to it. And you can also have what we call silver wiring. So there's sclerosis of the vessel.
Ew.
The symptoms will vary depending on the severity of the retinopathy. Vision can be normal and can range to a sudden decrease in it. You can have scotoma, so blind spots forming, and then for some patients, even double vision of the diplopia. Long list of signs when we're looking into the eye. So that narrowing that we were just mentioning of the arteries. You can have a crossing pattern change with the arteries and vessels, and that's what we call an AV licking. You can have that white fluffy spot, cotton wool spots going on, some hemorrhaging. Very classic pattern of hemorrhaging is what we call a flame-shaped hemorrhage. Have some microaneurysms. Exudations going on, so that bright yellow speck to the fundus. You can have some edema going on. And then a branch retinal or even artery occlusion. And you can also have dysedema, so the optic nerve head is swollen. Alright, so the arrow is showing some narrowing of the vessel. The exudate deposit can form a star pattern over the macula. So it's that starburst, that yellow starburst around the red part of that eye, that red spot. The stellate pattern right here. You guys see it on the side? It's that starburst, that star pattern over the macula. You can also have dysedema. That optic nerve margin is not very distinct. It's a little bit blurry. Right, so your workup, basically what you would do for a hypertensive patient. And you would treat last of our retinal conditions is toxicity due to chloroquine or hydroxychloroquine, caffeinol. Right, so the most critical risk factor for toxicity is going to be excessive daily dose by weight, and then the duration of the use of medication. So renal disease, tamoxifen use, retinal and macular disease are also risk factors, but the main one is going to be the dose and the duration. Symptoms range from decreased vision to changes in their color vision and difficulty adjusting to the dark. Classic sign for toxicity is what we call bullseye maculopathy. So over that macula, you'll see a bullseye pattern to it. Now, unfortunately, whatever happens and the changes that occur are not reversible. Even after you stop the medication, there could still be progression. So screening from when you would send your patient to us in the eye clinic, within the first use to get their first use of medication, we would get a baseline. And then we would monitor them annually starting at 5 years of medication use. And we would change that frequency depending on other risk factors if it's present. With the maculopathy, there is no proven treatment. So if I see it, I would not be the person that would discontinue the medication. I would reach back to the PCM or the prescribing provider, and that would be a discussion between the patient and their prescribing provider. All right, some pictures are included in your slide deck of bullseye maculopathy. So if you look at the macula, right, you'll see this bullseye pattern right over it. So same thing over here, this bullseye pattern over the macula. And another view of it. When there's visual fields loss, we'll pop a patient behind the visual fields machine. Any of you have had that done? So it's this machine that you'll have the patient look in. I always tell my patients it's like a hearing test but for your eyes. Instead of hearing a little beep, you click a button. Same time you see a flashing light, you click a button. We do this test one eye at a time. All right. And so each point is tested multiple times. And once we analyze the test, the darker the pattern, the more field loss there is. And so remember looking at the fundus photo, you saw that bullseye pattern over the macula. This translates over to a bullseye loss of vision on the visual fields test. And then there's another depiction of bullseye maculopathy. That is all of the new conditions for this block of retina. There are quite a few case study slides. Since we have some time, we'll go over a couple of them. So we have a 62-year-old male reports to your clinic after he noted strange waviness to his vision. He states that his vision may have started changing a long time ago. Sometimes it seems blurry, but it goes away. He says his mom also has similar symptoms, but she refuses to see the doctor. Right. Vitals, blood pressure 118/78, pulse 68, temp 98.5. Right. So when we go, it went from the optometrist standpoint, right, or if you're measuring your visual acuity, OU means both eyes together. They're seeing 20/25 with some sort of corrected lens. looking inside the eye, you note white deposits throughout the macula, and there's some hemorrhaging in the subretinal layer. This is what you see. And what are we thinking? Age-related macular degeneration. Very good. So again, we're looking in the macular region, right? You see some exudates, that white, yellowish speckle going on, and some pigmentary changes going on in that area. Right, 48-year-old male reports to your clinic complaining progressively worsening vision out of his left eye. Over the last 3 days, he noted that his vision has gone from just a bit cloudy to a complete loss of vision. He states that someone pulled a curtain over his eye. Initially, he noticed flashes of light and an increase in floaters before the loss of vision occurred. He denies any type of trauma. Medical history, hypertension, but no surgery. Vitals are there. Visual acuity is 20/25 in the right eye, it's an OD. And in the left eye, it's just dark, light and dark recognition, so light perception. Exam of the left eye reveals decreased red reflex. And the fundus is, looks like this.
That's a red attachment. Touched.
Yep, so retinal detachment. So remember, classic signs for is new onset of floaters, flashes light, curtain or veil covering parts of the vision. All right, 30-year-old female reports at the clinic complaining of progressively worsening vision at night. States that they're difficult to find a seat in a dark movie theater. She mentions that both her brother has similar symptoms and that her father is legally blind. The vitals are there. Visual acuity is 20/40 in the right eye, 20/50 in the left. And during the exam, there's noted changes to color perception. And this is what her fundus looks like. What are we thinking? RP, retinitis pigmentosa. So those little black spots are called bone spicules. All right, 66-year-old male reports to your clinic complaining of abrupt vision loss in his right eye. Notes that he woke with vision loss this morning, denies any trauma. Medical history is significant for hypertension and hyperlipidemia. Right eye is light perception only. Left eye is 20/25. You also notice that there's an aberrant pupillary defect. And then looking at the fundus, you notice that the retina is pale. This is what that retina looks like. What kind of occlusion? So central retinal artery occlusion.
So how would you differentiate with the picture in the case study, without the answer obviously, between the vein and the artery?
So your central retinal artery occlusion is going to be that pale fundus, whereas your
Okay.
central retinal vein occlusion is going to be all that hemorrhaging going on, so that blood and thunder fundus.
Anyway, artery occlusion, there's no blood being into the retina, so you're not going to have any bleeding. It's going to be pale.
Got it.
And then also the yeah, and cherry red spot. They weren't able to see that.
I have.
That is a medical bug.
Twenty-six-year-old female reports to your clinic and states, I can't see anything below my nose and my right eye. States that she has noticed similar symptoms 2 weeks prior to this visit, but she just thought it went away. Denies any other symptoms or signs, no history of trauma, no history of smoking, use of oral contraceptives, vitals are there, visual acuity is 20/100 in the right eye, uncorrected, and then 20/20 in the left. And then looking in her eyes, this is what you see. It's thunder. Is it all throughout the retina? Or is there just a section?
Just a second.
So if we're looking at this, if it was a whole entire retina, you can see it's all down here, it's like all up here as well. So it's not all throughout, so it's just a section of it. So it's being your CRVO and your VRVO, which one would you think it is? It's your branch retinal vein occlusion. Alright, that's the last of it. Went through it super duper quick. Any questions? Any clarifications? So like I said, yes, I'm an optometrist, but for the last 2 assignments, I have supervised PAs with the active duty clinic, with flight medicine as well. And a lot of times, y'all really don't like the eyeballs. No offense taken, a lot of people don't like the eyeballs either. But I do push my PAs to see and take a look in the back of the eyes. Army Mike does it differently, but a lot of the Air Force clinics, we don't have sick call. So a lot of times patients will call and I just don't have the availability to get everybody who has like a walking red eye to come in. And so I do push it on to our PAs to take a look and deductively kind of reason their way, is this something that needs to be seen urgently or is this something that could be seen a little bit later on and whatnot. Also when it comes to occupational health exams, one of the requirements is to look in the back of the eyes, right? So you will be looking into the back of the eyes with a direct ophthalmoscope. And so a lot of times I will reach out to them and establish like, hey, if it's a patient who is wearing contact lenses and has a red eye, then this is what you would do. So there's this working relationship between optometry and our physician assistants. So I think by learning, again, a lot of this stuff is just like, oh my goodness, what in the world, right? And we're throwing a lot of different conditions in front of you. But the whole point of it is to get you to realize what is a priority and what can wait a little bit. And if it's a priority, who do you need to send it to? Have you done your direct ophthalmoscope lab yet? Yeah. Was it difficult? Easy? I see a lot of people saying it's easy peasy, but it's easy. It was hard? Yeah. It is difficult. It is an art to it. And so definitely practicing